All right, now we're going to get into some interesting stuff. Not that it's not all interesting, but we're going to talk about hip motion and innervation. And so by hip motion specifically, I mean the kinematics of the hip. So it's the osteokinematics, and we'll briefly touch on the arthrokinematics, but not too much. So for all of the joints coming up, we are going to be in sort of the same format as we are doing for the hip. So we'll talk about osteology, we'll talk about the kinematics, we'll talk about muscles, and we'll talk about functional considerations for all of them. So that's sort of going to be the pattern going into the rest of the quarter. So for the hip, it allows a lot of motion, right? It's a place in our body where a lot of forces are being transmitted. There's a lot to do with our standing and walking and just general mobility. So because the hip is a ball and socket joint, it allows a lot of different motions. And that's great. We want that. We want all those different motions. So the learning objectives for this section are to be able to identify the joint types and the motions available at the hip. So it's a ball and socket joint, right? The head of the femur is articulating with the acetabulum. It's the ball and socket joint, which allows lots of different motions. And we'll talk about all the different motions available at the hip. And there are a lot of them, a lot of different motions and a lot of different kinematic strategies. So once we get into the innervation section, we want to know which motions of the hip would potentially be affected by damage to the individual nerves. So the innervation of the hip is actually pretty simple, thank goodness, right? But it has far-reaching functional implications when you have a nerve injury. And I have some good stories about that. So when we're talking about hip motions and kinematic strategies, there are 6 basic hip motions: flexion, extension, abduction, adduction, internal rotation, and external rotation. There's also circumduction, which isn't its own movement. It's a combination between flexion, extension, and adduction, and you get that circular motion. But the 6 basic motions are listed here and in your text, of course. So because the hip is so important in the junction between upper body and lower body, and in weight bearing and in movement, there are a lot of different kinematic strategies for each of those 6 motions. So you can have open chain hip motion, like walking, going upstairs, kicking a ball. That's all open chain, right? So closed chain hip motion, and there are 2 different kinds of closed chain hip motion. When the first one is where we maximize trunk displacement, like reaching down to pick something up off the floor, or where we minimize trunk displacement, and basically it's a pelvic tilt, and we'll talk about each different one. So for hip flexion is the movement between the femur and the pelvis in the sagittal plane around the medial lateral axis of rotation. So picture that in your mind. If you still have a piece of paper hanging around from the early lectures, sagittal plane and medial lateral axis of rotation, okay? So hip flexion reduces the distance between the anterior aspect of the pelvis and the anterior surfaces of the femur. So bending down to touch your toes, sure, that does that. So bending down to touch your toes or bending down to pick something up, that is a long arc, pelvic on femoral, closed chain hip flexion. Okay, so it's long arc because we're maximizing trunk displacement. The trunk is moving with the hips as we go down to get something. The pelvis is moving on a relatively fixed femur. The distal portion is fixed, so it's a closed chain motion. whoops. Let me go back to where we were. Since there's so many different images in this, I felt like we needed a different presentation format. So it's a little more complicated. So when we still move the anterior surface of the pelvis towards the anterior surface of the femur without displacing the trunk, we get that anterior pelvic tilt. So this can be very important functionally or in a clinical setting. If you're working with someone that has a type of back injury that is improved with lumbar extension, like a disc injury, and we'll learn way more about that in your orthopedics class. But there are some back injuries that are biased towards lumbar extension, and there's some that are biased towards lumbar flexion. So if you want to maximize lumbar extension, you want to have that short arc pelvic on femoral flexion, and that also known as an anterior pelvic tilt. So this shows it in standing, and then this shows it in sitting. So this is the short arc pelvic on femoral hip flexion. So the anterior part of the hip is moving towards the anterior part of the femur. We're getting lumbar extension. It's an anterior pelvic tilt. In the clinic, a lot of times people who either use a wheelchair for mobility or have other mobility issues, a lot of times we're working on an anterior pelvic tilt to get them in a better seated position so they're not doing damage to their back, or they're sitting on their ischial tuberosities rather than sitting back on their sacrum. So people that have a posterior pelvic tilt, and maybe they lost some trunk control, their trunk extensors are weak, they'll sit back on their sacrum and you can get a pressure ulcer on the sacrum. So that short arc, closed chain, anterior pelvic tilt or pelvic on femur flexion is really important functionally for healthy sitting. So that is something that we'll work on a lot with people. So in this position, this is the same, this is the long arc, closed chain, pelvic on femoral motion, and the lumbar spine is going into flexion. So if you have someone who has spinal stenosis or spondylolisthesis or spondylosis, you probably want to bias your exercise towards lumbar flexion. And so this long arc, pelvic on femoral, closed chain flexion is something that you want to incorporate into your exercises. Who knew, right? Okay, so those were all closed chain motions. So then when we're talking about open chain hip flexion, it's long arc, open chain, femoral on pelvic motion. So the femur is moving on a relatively fixed pelvis. This is crazy, right? There's a lot of stuff to remember. But the main thing to remember is it long arc or short arc? Is it closed chain or open chain? And is the pelvis moving on the femur or the femur moving on the pelvis? In open chain, the femur is always going to be moving on the pelvis. In closed chain, the pelvis is always going to be moving on the femur. Okay, so hopefully you're with me up to this point. Okay, so the next motion is hip extension. So hip extension is movement between the femur and the pelvis within the sagittal plane about a medial lateral axis of rotation, just like flexion, same plane, same axis, except hip extension reduces the distance between the posterior aspect of the pelvis and the posterior surface of the femurs. So muscles that are going to do hip flexion are going to be anterior to the medial lateral axis. They're going to have a line of pull that's anterior to the medial lateral axis. Remember that when we talk about hip muscles. Muscles that do hip extension are going to run posterior to the medial lateral axis. So same kinematic strategies, you can have closed chain or open chain, long arc or short arc. It can be the pelvis moving on the femur or the femur moving on the pelvis. So this one is open chain, long arc, femur on pelvis, hip extension. And so open chain is always going to be femur on pelvis, closed chain is always going to be pelvis on femur. This is long arc, closed chain, pelvis on femur, hip extension. And then the last one, this is short arc, closed chain, pelvis on femur, which is also known as a posterior pelvic tilt. And in a posterior pelvic tilt, you get relative lumbar flexion. In an anterior pelvic tilt, you get relative lumbar extension. So we'll talk a little bit more about anterior and posterior pelvic tilts and which force couples of muscles work to do those rotary motions. That's in a later lecture. Okay, so we did hip flexion, hip extension. Now we have hip abduction, abduction. We have open chain and closed chain. So we have in open chain, it's femur on pelvis. In closed chain, it's pelvis on femur. Okay, so hip abduction is the movement between the femur and the pelvis in the frontal plane on an anterior posterior axis of rotation. Okay, so flexion and extension happen in the sagittal plane with the medial lateral axis of rotation. Hip abduction and adduction happen in the frontal plane with an anterior posterior axis of rotation. So different plane, different axis. Hip abduction reduces the distance between the iliac crest and the lateral aspect of the thigh. And largely with the muscles involved, it's the distance between the iliac crest and the greater trochanter of the femur. So we can imagine that muscles that are lateral to the anterior posterior axis are going to perform hip abduction. Muscles that are medial to the anterior posterior axis are going to perform hip adduction. So open chain hip abduction, the femur is moving on a relatively fixed pelvis, and the hip adductor muscles are going to be on stretch. The abductor muscles are going to be doing the work. So I think that's pretty straightforward. Open chain, femur on pelvis. And luckily with this, there's no long arc or short arc. That's only with flexion and extension. So for closed chain, pelvic on femoral, hip abduction, the foot is planted, the distal portion is fixed, the pelvis is moving on the femur. So this can look like, so this is a closed chain, pelvic on femoral, hip abduction on the right. It can look like a hip hike on the left. Okay, so you can see how that works. But it's the right hip abductors that are doing the motion in this case. Okay, so we have hip abduction, we have to have hip adduction. So hip adduction is the movement between the femur and the pelvis in the frontal plane with an anterior posterior axis. So just the same as abduction. Adduction results in reduced distance between the midline of the pelvis and the medial aspect of the femur. So muscles that perform adduction are going to run medially to the anterior posterior axis going through the hip. Makes sense, I hope. So the open chain motion is the femur moving on a relatively fixed pelvis and reducing the distance between the midline of the pelvis and the medial aspect of the femur. The closed chain motion is the same thing, reducing the distance between the midline of the pelvis and the medial aspect of the femur, but it's the pelvis moving on a relatively fixed femur. So it can be seen, so this is the right hip adduction, closed chain, pelvis on femoral motion. It can look like a left hip drop, okay? So then we have rotation. So we have the same closed chain and open chain. With closed chain, it's the pelvis moving on a relatively fixed femur. Open chain, it's the femur moving within a relatively fixed pelvis. So internal and external rotation occur in the horizontal plane about a vertical or longitudinal axis of rotation. And so if you plant your foot and rotate your trunk, you're getting closed chain, internal or external rotation of the hip, depending on which direction you're moving. In the clinic, this is important if you have someone that has hip precautions from a total hip replacement. If they have a posterior total hip replacement, they are restricted from doing internal rotation and adduction and flexion. If they have an anterior or anterolateral hip replacement, they're restricted from doing external rotation. So you don't want them to plant their foot and then turn towards the operated leg or away from the operated leg, depending on which motion you're trying to avoid. So think about it, try out some of the motions and see if they make sense to you. Hopefully they will. So just think about whether the the pelvis is moving on the femur or the femur is moving on the pelvis. If it's closed chain, the pelvis is moving on the femur. If it's open chain, the femur is moving on the pelvis. And then that'll affect your convex concave. And in the book, they do go into very detailed convex concave relationships between all the joint surfaces, and I'm not going to expect you to know that now. In the future, when you start doing joint mobilizations, that's when you're going to need that information, but I'm not going to expect you to know it now. So the last portion, we're going to talk about the innervation of the muscles of the hip, which is pretty simple, thank goodness. The femoral and obturator nerves are the two largest nerves that exit the lumbar plexus. The femoral nerve and their femoral and obturator are all in the L2, L3, L4 region of the spinal cord. Come off of that region. The femoral nerve innervates most of the hip flexors and all of the knee extensors. So hip flexors and knee extensors are some pretty important players in functional mobility. And so the femoral nerve's pretty important for, walking, standing, getting out of a chair, all that stuff. The obturator nerve innervates primarily the hip adductor muscles. Okay, so you can think of the anterior muscles, femoral nerve, the medial muscles are the obturator nerve, and then the other nerves that innervate the hip are the sciatic nerve, and then there's some what we call early exiting nerves that exit off the sacral plexus, and I'll talk about them. The sciatic nerve is the largest nerve in the body, and it's composed of the tibial nerve and the common peroneal nerve. So I think of it as like the wired headphones that you'd get, and they were all together all the way to the end, and you had to sort of peel them apart so you could get the headphones in your ears. The tibial portion and the common peroneal portion are the two parts that you peel apart, and then the main nerve trunk that comes out of the sacral plexus is the part of the headphones that are still together. That's my analogy. I hope it works for you. If it doesn't, we'll come up with something else. So on the tibial portion of the sciatic nerve innervates most of the hamstring muscles and the extensor head of the adductor magnus. So it makes sense. The posterior nerve, the sciatic is the main posterior nerve, and it innervates the extensors, which are on the posterior surface. Makes sense, right? The common peroneal portion of the sciatic nerve innervates the remaining hamstring, the short head of the biceps femoris, and a lot of muscles lower down in the legs. So we'll talk about those in the next few chapters. So really the main thing is the tibial portion of the sciatic nerve. That's the main thing that's innervating our hip muscles. And it's going to be our hip extensor muscles. Okay, I keep messing up my sequencing on my presentation. Okay, femoral and obturator nerves. So femoral anterior, obturator medial, sciatic posterior. So femoral flexors, obturator adductors, and sciatic extensors. Hopefully that makes sense. We also have other nerves from the sacral plexus that innervate the gluteal muscles, the tensor fasciae lata, and the deep hip rotators. 5 of the 6 of them. The piriformis has its own nerve, just to make it interesting. So all of the other little muscles are named. They have individual nerves that are named for them. So there's a piriformis nerve just for the piriformis. The superior and inferior gluteal nerves innervate the gluteal muscles. So each of them sort of have a name that goes with the muscle name, if that makes any sense. So here's a quick summary of innervation. The femoral nerve, the nerve roots, spinal nerve roots are primarily L2, L3, and L4. It innervates the iliacus, hip flexor, rectus femoris, hip flexor and knee extensor, sartorius, hip flexor, and a few motions at the knee that we'll talk about later, and the pectineus, adductor and hip flexor. So I would almost classify the pectineus as a hip flexor, even though it does have a little bit of an adductor line of pull because of its innervation. It makes me go hip flexor on it. The obturator nerve, also primarily L2, L3, and L4, innervates the gracilis, hip adductor. Pectineus has a head for adduction. Adductor longus, brevis, and magnus, adduction. Okay. The adductor magnus has an adductor head and an extensor head. The adductor head is innervated by the obturator nerve. The extensor head is innervated by the sciatic nerve. So the sciatic nerve, its nerve roots are a little lower down, L5, S1, S2. It innervates the semitendinosus, semimembranosus, and the long head of the biceps femoris, so the 3 big hamstrings, and the extensor head of the adductor magnus. And we'll talk about the muscles in detail: origin, insertion, action, and innervation. The superior gluteal nerve, if you think about it, if you put your hands on your iliac crest, which is where the gluteus medius originates, it is a little bit higher than the gluteus maximus, so superior gluteal nerve. Gluteus medius, gluteus minimus, and tensor fasciae lata, they're all in the neighborhood. Inferior gluteal nerve is the gluteus maximus. So big hip extensor, and it has its own nerve, primarily L5, S1, and S2 for all 3 of those. And then the little nerves that have the little muscles that have their own nerves. So by looking at this list, you can see which motions might potentially be affected by damage to these individual nerves or nerve root levels. So if you damage the femoral nerve, it's going to affect hip flexion. If you damage the obturator nerve, it's going to affect hip adduction. If you damage the sciatic nerve, it's going to affect hip extension. Okay, this all makes sense, right? If you damage the superior gluteal nerve, it's going to affect hip abduction. And if you damage the inferior gluteal nerve, it's going to affect hip extension through affecting the gluteus maximus. So by the hip innervation is great and simple, easy to remember, and hopefully that will all make sense to you.